Today we'll be learning about the carpal tunnel syndrome. Now look at, here I'm showing you a wrist joint. And there the bones who are contributing here. These are the carpal bones, and this is the lower end of the radius, and this is the lower end of the ulnar bone. So now let's have a section at this level. When we cut a section at this level, what we're going to see, look at the same carpal bones, the outer skin, and then where we can see there are so many tendons, and these are on the posterior side, they are the extensor tendons, and those who are in the anterior side, these all are the flexor tendons. And you can see there are certain vessels. Can you see these openings? So, and there is some fibrous structure. Let's explore it further. What are the things? So these are the labels, and then you have to match with all these. Now let's look at a section. So this is a schematic picture, and there we can see, label these carpal bones. So these carpal bones, number 1 is my hamate, number 2 is my capitate, and 3 is my trapezoid, and the 4th one is my trapezium. So these are the bones, and then these are my extensor tendons, long extensor tendons, and inside we can see there are some more tendons which are coming up. This is my flexor carpi radialis tendon. Then I have flexor pollicis longus tendon. Look, everything which appears in a box, that is inside my carpal tunnel. So now this one is not in a box, so it means this tendon is out of my carpal tunnel. And now look at these 4 tendons. If you see the tendons like this, 2 on above and 2 below, these are always, this is the arrangement of the tendons of my flexor digitorum superficialis. And then those who are in a sequence, these are the tendons of my flexor digitorum profundus. And now look at it. To minimize the friction, there is the synovial sleeves has been placed in between, so these tendons should have a very easy movement. It shouldn't. So, and this is collectively known as the ulnar bursa. That's the name. And then now you can see that there is this is a nerve, and that is my, what do you think whose this should be? This is my median nerve. And now can you see this gray band which is extending from my hamate and going all the way to trapezium, and it splits here. It encloses my flexor carpi radialis tendon, but this is out of this internal area, and that's my carpal tunnel. Why we call it tunnel? It is made up of bones and then is bridged by this fibrous band which is famous with the name of the flexor retinaculum. There are other names for this, but you simply remember flexor retinaculum. Then we are going further. There you can see there is a tiny structure. Who's that? This is one of the superficial branch which emerged from my median nerve. So it's not going through that. And that is named palmar-cutaneous branch of the median nerve. And there you can see ulnar nerve and ulnar artery that has been shown, and they are also outside of my flexor retinaculum. And then you can see here someone is hiding, and that is the radial artery. This was the ulnar artery and ulnar nerve. And this is the tendon of my palmaris longus muscle. Now, what is carpal tunnel syndrome? Basically what happens, the median nerve got trapped, and when it got trapped, once there is some problem, when this tunnel becomes narrow, and there are different conditions. So there are certain osteoporotic changes are one of the factor, some fluid can fill up, pregnant women, and mostly those who are affected, these are the females. And once the intracompartmental pressure is rising, so the muscles are affected, but the nerves are affected more. And which nerve is there? With all these muscles, there is only one nerve, and that is my median nerve. And once there is the pressure coming on my median nerve, that will result, it starts with a pain, and when you start moving your fingers, when you start working, you will getting pain is becoming more and more and more. and this pain is followed by loss of sensations and so many other type of modalities. And ultimately there is loss of the thenar eminence, atrophy, the atrophy of my thenar eminence muscle. What are the thenar eminence muscle? Thenar eminence muscle are those who are, if you look into your palm, you can see that there is a little heave just at the base of your thumb. This is the thenar eminence. There are various ways how to treat that. We are not focused on the treatment a lot, but simply if you split this, medication has been used, but the ultimate treatment is the split. You can split this, you can clip this flexor retinaculum, so this tunnel can be open, and that's the solution. Now you can see that a fluid has been filled up, and now this is the situation which we call it as the carpal tunnel syndrome. Now this is another image showing the same what we have looking at, but now one thing I have to say, we use these carpal bones, hamate, capitate, trapezoid and trapezium. But remember, this is example A, and we have 8 in total, 8 carpal bones. So this is, you are looking at one sequence, and there is the next. So no matter if any of book is mentioning these bones or these bones, it's the same. You can see that they are also bridged by the flexor retinaculum. Same goes here. So the bottom bones can be named like this or can be named these carpal bones. So both of them are acceptable. Don't get confused with this. Oh, we learn in a lecture today about hamate, capitate, trapezoid and trapezium, and my book is writing about pisiform, tricuteral, lunate and scaphoid. Now we all know what is happening. This guy is falling down. We know him. Yes, last time he broke his clavicle, but today the situation is different. Clavicle is more seen in the children, and in adults there are more sequencing. And now let's see what happens. This guy slips because the floor is wet. You can see this sign, and now he is falling on his outstretched hand, and it has been labeled, it has been called Foosh, F-O-O-S-H. And now look at the X-ray. What finding you can see this in this X-ray? Look at it. The distal fragment of my radius is being separated, and now this bone is being overlapping. So let's label it, let's highlight it. You can see that the broken fragment of my distal radius, and this red is indicating the part from where this part has been detached, but it's not only staying in its location, it also deviates. So it is coming, it is overriding the lower part from where it has been separated, and it has moved on the side. Which side? Radially, and you can see in this same image. So now you can see that this broken fragment is overriding the main bone, the remaining bone, and it is going laterally. Who's doing this? We know a muscle, brachioradialis. That muscle is attached onto this. This is called the distal part, and there we have the attachment of my brachioradialis. And because of that, this fragment of the broken bone, it stays up. How? We can see in the coming X-ray. Look at it. So now look at it. The broken fragment, the distal fragment of the broken fragment is above, and the main bone is below. Why it is above? Because this tendon of my brachioradialis keeping him in his position, and the bone, as it's been detached from here, so the distal end of my broken radius is been falling down. But the lowermost broken segment, which was separated out from this bone, that stays where it is, and the reason behind is because it is been anchored by my muscle called brachioradialis. Let's label him, and let's label the remaining bone. From where? So this blue is the bone, the lower end, this is from where this yellow thing is being detached, and that is famous with the name of this styloid process. And you can see the same example, and the reason I have explained to you, and this is important. Now we call it Colles fracture. And now look at it, the similar thing, but you can see there is something more. So this carpal bone is my scaphoid bone, and one of the most commonly fractured carpal bone is the scaphoid, and usually it is being missed. And then if we ignore this one, it comes up with disaster. So let's see what happens. So in the Colles fracture, most commonly fracture in adults. In the children, we find the clavicle with a similar type of thing. And now the radius, and you can see this, the radial styloid, and this is my ulna bone, and look at it, the broken, the fracture site, and see now. If this scaphoid bone is fractured, there is fair enough chances that this bone can undergo avascular necrosis. And now you can see that the hand adopts a typical shape, and that is called the dinner fork type of deformity. And look at it, this fracture segment can affect this median nerve which goes so close to it. So there might be an association of the injury occurring to this median nerve. This is a possibility. You can see that how sharp the broken edges of my distal radius. Are we good so far? Yes, this is a median nerve injury, which is a possibility. Now let's look at it. We all know this is a dinner fork, and look at the hand, how it goes in this dinner fork of deformity. If you see someone who's falling on his outstretched hand, and if you see his hand like this, the first thing which should come in your mind is the Colles fracture. And this is the X-ray of the same person, and look, this is what happens in this drawing, and see that this fragment stays and the rest of the bone is being falling out. Now look at it at the base of my thumb. Can you see this raised area? So this person has also have a history of fall, and now, but there is no dinner fork deformity. So when the X-ray has been taken, we find something interesting. First, let me show you the images. So look at it. So this person has fractured his scaphoid, and there are the different views of the fractures of the scaphoid, and you can see different location where a scaphoid can be fractured. Now look at this X-ray, and we are seeing here all the carpal bones. So let's identify where is the scaphoid bone. Let's highlight it, and where is the fracture? Can you see with this green? And on this one you can see with this red circle, this is my fracture which has been seen within the middle part of my scaphoid bone. And then now we can see in this image, look at it, the fracture sites. Now look at different images of scaphoid. What you see here, there are numerous openings, and these openings, they are helpful for entry of my nutrient arteries. And if the scaphoid fracture in the middle, nothing goes wrong, it will heal. But if this fragment is fractured, look at it, there is no nutrient foramina, and this bone is detached from the main bone, so this will not be getting oxygenated blood. So this part can undergo avascular necrosis. That's really important, and we need to understand. So now we are done with the carpal tunnel syndrome as well as the Colles fracture and the scaphoid fracture. These are very important conditions. Now look at someone's posterior aspect of the forearm. This is just a hand. Let's put the bones here. The bones are my radius and ulna, and there are the muscles. So we'll be learning. We have just learned this section before. Just a quick recap. We are good with that. The outer core is the skin, and then superficial fascia and the deep fascia. Just for a quick review, I'm just going fast on that. So the muscle who will be learning right now in the posterior compartment or the extensor compartment, their job is they extend the wrist and the digits, and they are the supinators. And the nerve who controls them is the posterior interosseous nerve, and the radial nerve. Posterior interosseous nerve is the deep branch of my radial nerve. Now, this is a cadaveric hand, and you can see the posterior aspect, and you can see so many tendons, which we'll be learning shortly in our upcoming sketches. So now these are the bones. You can see the interosseous membrane. This is the ulna, that's the radius. And at the bottom you can see the carpal bones and the metacarpal bones. For the purpose of our learning, we learn these muscles in two layers. So the superficial layer, the muscles here are, most of them, they are innervated by my posterior interosseous nerve, but there are certain exceptions. And what are these exceptions? One of the muscle, extensor carpi radialis longus and coneus, they are innervated by radial nerve. And the other one, all of them are innervated by the deep branch of the radial, which is the posterior interosseous. So now this is from the lateral epicondyle of my humerus, we have this common extensor origin. And look at it, the first muscle which is going to the radial side to the base of my second digit, that is my extensor carpi radialis longus, and this muscle is innervated by radial nerve. And it goes where? At the base of my second metacarpal. Then we have another muscle. So we have two extensors here with a similar name, and this one is my extensor carpi radialis brevis. One is long, one is short, and it is innervated by my posterior introitus, and that goes to the base of my third metacarpal. And then can you see this big muscle which is coming from so many areas, and this is my extensor digitorum. On the extensor side we don't have many muscles like on the flexor side, where we have flexor digitorum superficialis and profundus. Here we have only one, and that's my, you can see it breaks up into its these attachments, and they all are designated for digit 2, 3, 4 and 5. All the slips from this muscle, all the tendons from this muscle, they are going to be attached at the distal phalanges of my 2nd to 5th digits. And then you can see that these tendons, they are connected with each other, and they are controlled by dorsal digital expansions or extensor hoods. We have discussed this matter in the previous lecture, where we were learning about the anterior compartment muscles of the forearm. And now you can see that the one muscle which is almost coming from my extensor digitorum, but that's going to my 5th digit, and this is famous with the name of extensor digiti minimi. And then the last one which is going to the base of my 5th digit, and that one is my extensor carpi ulnaris. Regarding extensor digiti minimi, some authors, they believe this is the detached part of the extensor digitorum. So we have covered by this, except for one, we have covered almost all of my superficial layer muscle. And who's the last one that is coming up? And that one is my enconius. And we have said in the beginning, this enconius and this extensor carpi radialis longus, they are innervated by the radial nerve, and after this the radial nerve divides into a superficial and a deep branch. Deep branch is known as the posterior introitus. So now, same like when we learn in the flexor compartment lecture, there is a possibility of excessive use of the flexors. So there can be medial epicondylitis, and that was also famous with the name of the golfer elbow. So similar can happen for the extensors, and if that is happening, in this case the lateral epicondylitis, that is famous with the name of the Tannis elbow. Okay, so what are the action of these muscles? Other than enconius, they all extend the wrist joint and the digits, and the extensor digiti minimus is a accessory muscle, as I said already, and it may be there, it may not be there. Now this is a diagrammatic representation of the same muscles that we have discussed so far. So you can see them together. Brachioradialis, I have not mentioned it here because we have discussed it previously, but that is also one of the muscle which belongs to my superficial compartment. And then you can see the extensor carpi radialis longus, and then the brevis, and then we have digitorum, digiti minimi, and the ulnaris, and last but not the least is my enconius. And now let's look at the deep group. In the deep group, all of them are innervated by my posterior introitus. Look at this. We were talking about this muscle from the beginning. That is my supinator muscle, and this is the second major supinator. The first major is my biceps brachii. Look at it, which nerve it should be. This is my radial nerve, and this radial nerve, when it reaches here, it divides into its superficial branch and deep branch. It goes behind that. You can see that it pierces through this muscle. What is this muscle? Supinator. So that's the deep branch, and that's the superficial branch. After supplying the two muscle here, the radial nerve, after supplying the two muscle, what were those two muscle? Extensor carpi radialis longus and enconius. This nerve divides. The deep branch pierces the supinator to go into the deep group, and the superficial branch, now it's not supplying any muscle, and it becomes continuous. It goes down to my hand, and it just supply the skin. It's now sensory. And this is the deep or the posterior introitus. So now we are looking at a muscle which starts from the introitus membrane, little bit from the radius and ulna, and then it going to the base of my first digit. Which part? The metacarpal. Remember, my first digit don't have three phalanges. It has proximal and distal, and this is my metacarpal. So the muscle which goes to the base of my first metacarpal, that muscle is my abductor pollicis longus. The word pollicis is designated for the first digit or the thumb. And then there is another muscle which goes to the base of my proximal phalanx, and that one is, which is shown with this pink color, extensor pollicis brevis. And now the next one, which is going to the distal phalanx, this brown one, that is my extensor pollicis longus. There is something is being formed in between these two tendons and this tendon. We will be learning about it in the next session, and that is my anatomical snuff box. So now how we identify these muscles? The abductor pollicis longus is attached to the base of my first metacarpal. The extensor pollicis brevis attached on the base of my proximal phalanx, and the extensor pollicis longus is attached at the base of my distal phalanx. We don't have a middle phalanx in the first digit. And what these three muscles are doing, their big job is to move the thumb. And now there is one which goes to my index finger, one muscle for one action, and this is my extensor indicis, very powerful muscle. And it goes to the base of my distal phalanx of the index finger. That's why it's called extensor indicis. Now you can see that this is my posterior interosseous nerve, and you can see that it's supplying all four of them. And then it's been next to it, what you see here, this is my posterior interosseous artery. Guys, we always get confused. Posterior interosseous artery is a branch of common interosseous artery. You remember in the flexor compartment we said common interosseous artery, which is coming from ulnar artery, divide into anterior interosseous, which was serving for my anterior compartment, and the posterior interosseous, which is serving my posterior compartment. And when we talk about the interosseous nerve, so anterior interosseous nerve is a branch of my median nerve, and posterior interosseous is a branch of my radial nerve. So this place most of you get confused, so please correct yourself. So we all know that these three muscles, they are help in moving the thumb, and they are contributing in making the boundaries of the anatomical snuff box. We'll be learning about it in the next session. So now we can see the same diagram, images of these muscles which we have just talked about, the deep group of muscles. Similar things. Now let's summarize what their job is. They are the extensors of my wrist and the digit, and plus the supinate. The nerve is posterior interosseous, which is a deep branch of my radial nerve. But I am using a word here, except two. Who are these two? Anconius and extensor carpi radialis. They are extensor carpi radialis longus. They are innervated by radial nerve directly. And all of them, they receive their blood supply primarily from posterior interosseous artery. We divide this into two layers. The superficial layer muscle, we learn about 6 muscles there, and I'm sure everybody knows we have extensor carpi radialis longus and brevis and conius, and then we had the other muscles. And all these 6 muscles, out of them 2 are innervated by extensor carpi radialis longus and anconius, and the remaining 4 are innervated by my posterior interosseous. Now what are these 4? Extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris. And then we are going to the deep group, deep layer. It has 5 muscles, and they all are innervated by posterior interosseous nerve. And here you can see this is my location, and there you can see these 2 tendons. We talk about all of them, and this green area is showing you the anatomical snuff box. We'll be learning about it in the next session. Thank you very much.